We're fortunate this morning to be joined for the next hour by Dr. David Leaf. So Dr. Leaf received his undergraduate degree from the University of Pennsylvania and his MD from NYU. He then subsequently completed an internal medicine residency at Columbia and his nephrology fellowship at the Brigham Mass General Combined Program. He's currently assistant professor of medicine at Harvard Medical School and director of clinical and translational research in acute kidney injury in the Division of Renal Medicine at the Brigham. And he's collaborated, I know, with some of our faculty here, and we're fortunate to have him join us this morning. So welcome, David, and thanks for being here. I think you may be muted if you're trying to speak. I don't hear you. Does anyone else? No. Can't hear you. Sounds good.
Okay, let's try again. Can people hear me now?
Yes.
Great. Okay. Let me share my screen. And you can still hear me?
Yep, we can see it, hear you. It sounds great. Thanks for being here.
Okay, fantastic. Okay, great. So thank you so much for having me. It's really an honor. And I'm very excited to talk to you about some of the research we've done on COVID. So this really is not a AKI talk. It's really not even a nephrology talk, but hopefully it's still relevant to everyone, unfortunately, since the pandemic is still very much with us. So I have no disclosures. So just to give you a brief background about me, most of the research that I do when I'm not doing COVID research is related to AKI. So I do biomarker studies, I do clinical trials, a little bit of genetics, a little epi, and my interests within AKI actually overlap a lot with interests in from your division, including interests in FGF23 and vitamin D. We've been sending our samples to Andy Hufnagel for almost a decade now. I also have interest in onconephrology, and we've collaborated with Bilal. But I'm not going to be talking about any of that today. Instead, we're going to be talking about my project called Stop COVID, including the origins of Stop COVID, patient and hospital level risk factors for death, and what I'm really excited about, which is target trial emulation to identify effective therapies. So if we think about clinical research in COVID-19, or even just clinical research in general, we really have two flavors. We have randomized controlled trials, and we have observational studies. RCTs are, of course, standard for establishing therapeutic efficacy, but they're expensive and slow. And because they're expensive and slow, they're often underpowered. They often rely on surrogate endpoints, and they often have limited generalizability due to strict inclusion and exclusion criteria. Observational studies, on the other hand, are subject to residual confounding, but they can be helpful in identifying risk factors and in prognostication, in triaging and resource allocation planning, and in informing clinical decision-making when data from RCTs are unavailable, as we'll talk about. Thus, early on in the pandemic, And even now, to a large extent, there was an urgent need for high quality observational studies in COVID-19, particularly in the US and particularly in critically ill patients. And I emphasize high quality because there have been so many studies published on COVID-19. A few months ago, I just typed COVID-19 into PubMed and got 121,000 hits. And I did it again yesterday, and it's almost 200,000, which is really something. But needless to say, not all of these studies are high quality. And there have been editorials written about whether research quality is being compromised during the pandemic. One of the funnier editorials that I read was by a hematologist from Imperial College London, who wrote back in August, how to explain this burst of publications. Most scientists' laboratories are closed and they work from home. Their options: help with online schooling, cook dinner, vacuum, or hide in your newly designated home office and complete a long delayed manuscript. The choice between publish or perish has never been starker. So particularly in the setting of critical illness, existing studies on COVID-19 have been limited by small sample size, short follow-up, poor data granularity, and limited generalizability, with many studies just being single center. And again, this was true in the beginning of the pandemic, and it's still true today. Thus, the unmet need was creation of a large, detailed, and nationally representative database of critically ill patients with COVID-19 in the US. Such a database would include detailed data on demographics, comorbidities, symptoms, vital signs, physiologic parameters, lab data, organ support and organ injury, treatments, and outcomes. So how did this come about? So on January 21st of 2020, we had the first case of COVID-19 reported in the US from Seattle, of course. A few weeks later, on February 28th, our second child, Teddy Oliver Leaf, was born, which is not terribly relevant, except for the fact that a few days later, we had the first COVID-19 case reported in Massachusetts. And then on March 14th, I woke up with a fever and a cough. And of course, I was convinced that I had COVID. I couldn't get tested at that time. Testing was not widely available unless you were very sick, which fortunately I wasn't. And at this point, we had a 2-week-old baby, and we still weren't really sure, about COVID and its risks to children. And so my wife and I made the decision that I would quarantine in our bedroom while my wife took care of our newborn, along with our 2-year-old daughter, in the rest of the apartment. And so for about a week, I was just sitting there in my pajamas with my laptop. And I just started sending emails to colleagues around the country, people, friends from medical school or residency, or people who I've worked with in on other projects. And I asked if people would be interested in getting together and putting together a large database of patients with COVID-19. For the most part, these were nephrologists, because that's just my network, but it also included cardiologists and infectious disease people and a lot of different specialties. And pretty much everybody that I contacted was very excited to participate. We didn't have any funding, but that didn't seem to matter. And so we launched this project called Stop COVID, which stands for Study of the Treatment and Outcomes in Critically Ill Patients with COVID-19. It's a multi-center cohort study of critically ill adults with COVID-19 admitted to ICUs across the US. We ended up enrolling over 5,000 patients from 68 medical centers across the country. The medical centers, including UW, these are for the most part large tertiary care academic centers like my hospital, Brigham, MGH, UW, UCSF. You get the point. There were also a few smaller hospitals as well, but for the most part, these were large centers. We ended up having over 400 collaborators entering data, and these collaborators ranged from attendings to fellows, residents, medical students, research coordinators, nurses, basically anyone we could find who would be willing to help us out and enter data. And people were extremely enthusiastic about helping. They really believed in the project. The other way, one of the ways that we were able to also incentivize people was that we said everyone would be a co-author on every paper. Now, I've never had a paper before with 400 co-authors, so it was a learning experience about how to do that. But basically, we have a writing committee consisting of several dozen people on each paper, and everyone else gets put in the supplement, but their names still show up on PubMed. Each of the patients, each patient enrolled had over 800 data elements collected, and these were each collected by manual chart review. And we did this using REDCap, which is, I'm sure many of you are familiar with. REDCap is a HIPAA compliant web-based data collection platform. So there's no special software needed. All you need is an internet connection. It's very user-friendly. It has a lot of advanced features like branching logic and automated data validation. And again, all data were extracted by manual chart review, which took about 1 to 2 hours per patient. Now, the lab data alone were quite daunting because we collected over 20 pieces of lab results on a daily basis for 14 days. So that 20 times 14 is 280. So that's 280 questions just for the labs. And if we had that such that it was 280 questions, one on top of another, it would take forever just to scroll. So we were able to create this matrix, which made it much faster to enter the lab data. So the three primary goals of Stop COVID were to study the clinical features and outcomes of critically ill patients with COVID, including death and acute organ injury, to assess inter-hospital variation in treatment and outcomes, and arguably most importantly, to perform causal inference analyses of the effects of treatments on outcomes, which is really the holy grail of observational research. So here's our initial timeline. Between mid-March and mid-April of 2020, we built the REDCap database with 800 plus questions. We established collaborations with 65 medical centers, eventually it was 68. We executed 65 separate IRB approvals and 65 separate data use agreements, and we collected data on the initial 2,000 patients. We then gave ourselves 3 days to clean and validate the database, which at this point had over 2 million individual data elements. We gave ourselves another 3 days to analyze the data, make all figures and tables, write the paper, and collate comments from over 200 co-authors, which eventually would be over 400, but at this early stage it was 200. And then on April 21st, we submitted our initial paper to NEJM. And as an AKI researcher, I don't submit many papers to NEJM, so I just thought the review process was interesting. I would just share a little bit with you guys. So it was sent out for ultra rapid peer review to 3 reviewers, which means the reviews were all completed in less than 48 hours. All 3 reviewers gave it highly favorable reviews. The paper was then discussed at full committee. It was then sent out for in-house biostatistical review. No major concerns were identified. It went back to the full committee, and I'm following all of this, on their portal, and I'm, ready to get the acceptance letter. I'm all excited, and we get the rejection letter. And we appealed with a detailed point-by-point rebuttal letter, and even offered to throw in some data on tocilizumab and its effects on mortality. It was discussed again at full committee, and again it was rejected. And the reason it was rejected was they said at this point in the pandemic, and this is May of 2020, they said that they really just wanted randomized controlled trials. So we ended up publishing the paper in JAMA Internal Medicine, which we were very pleased with, back in July of 2020. And for this initial paper, we looked at patients who were admitted very early on, so between March and April of 2020, and patients were followed until hospital discharge, death, or until June 4th. So all patients had at least 60 days of in-hospital survival data. We collected data on demographics, comorbidities, home medications, and symptoms prior to hospital admission. ICU admission served as time 0. And starting with ICU admission, we collected daily data on physiologic parameters, labs, acute organ injury, and organ support. And we, of course, followed patients to see how long they stayed in the hospital and if they survived. In addition to these patient level factors, we also collected several hospital level factors, including the city and state of the hospital, whether it was the main hospital versus a satellite or affiliate hospital, hospital size. And hospital size is kind of tricky in terms of how to assess that, but we used the number of pre-COVID ICU beds as a surrogate for hospital size. And we also looked at what we refer to as regional density of COVID as a surrogate for hospital strain. And we determined this using data from the Johns Hopkins website, where they track the number of patients in each county over time with COVID. The primary outcome was 28-day in-hospital mortality. Secondary outcomes are shown here. So this initial study had a little over 2,000 patients from 65 hospitals. These are very sick patients, so roughly 2/3 were receiving invasive mechanical ventilation on ICU admission. Roughly half were receiving vasopressors. The in-hospital mortality at 28 days was 35%. And if you followed patients out until the end of the study, which was on average about 60 days, the mortality was 40%. So univariate risk factors for death. These are what are known as butterfly graphs. So on the left side of the x-axis is frequency. On the right side of the x-axis is 28-day mortality. And I'll just point out a few interesting findings. Of course, this striking relationship between age and mortality. So race and ethnicity was interesting. There's been a lot of talk about disparities during the pandemic. We did not see a difference in mortality risk in univariate analyses, at least, in Blacks versus whites or other ethnic groups. BMI, we did not see a relationship. When we looked at coexisting disorders, ESRD had the strongest relationship with death. And then just a few other things I'll point out. So we had a couple dozen pregnant women in our cohort. None of them died. We also had some healthcare workers. The mortality there was 10%, which was much lower than the overall mortality. Among all the symptoms prior to hospital admission, confusion had the strongest association with mortality. And then hospital size, which again, we assessed using number of ICU beds. So what we did is we categorized this into 3 groups: greater than or equal to 100 ICU beds, 50 to 99, or fewer than 50 beds. So large, medium, small. And what you can see here is that patients who were admitted to smaller hospitals had a much higher mortality. I'll show you the multivariable model in a sec. And then geographic region, patients in the Northeast had a much higher mortality compared to other regions of the country. Not surprising, because remember, this is early on during the pandemic when the Northeast really got hit very hard. Okay, so what about independent risk factors in the multivariable models? So age remained highly associated with death. You can see the odds ratio for those greater than 80 was 11. Male sex was associated with a greater risk of death. BMI, yes, but really only once you hit a BMI of 40 or higher. Coronary artery disease, cancer, and 3 or fewer days from symptom onset to ICU day 1. So people who progressed very rapidly from symptom onset to ICU admission. A few other covariates that were strong predictors. So the degree of hypoxemia on ICU admission, as assessed by the P to F ratio, and higher SOFA score points for both coagulation, liver, and renal components of the SOFA score. And then at the bottom, I've highlighted this issue again with number of ICU beds, where patients who were admitted to smaller hospitals having a more than 3-fold higher risk of death compared to patients admitted to larger hospitals. And again, this is multivariable. When we looked at acute organ injury, in terms of both incidence on the left and mortality association on the right, I'll just highlight that acute kidney injury, shock, and coagulopathy all had very high mortality associations. And then when we looked at timing of acute organ injury, so this is a floating bar graph. So each bar shows the median and interquartile range. The x-axis is the number of days from symptom onset. You can see that respiratory failure and ARDS tend to occur earlier. AKI and shock tend to occur a couple days later. And liver injury and thromboembolic events tend to occur later. Now, what about interhospital variation in treatment and outcomes? So these are what's known as caterpillar graphs, which is nice because we had butterfly graphs before, and now we have caterpillar graphs, although they probably should have been, the caterpillar graphs probably should have come first. So these graphs basically show the risk and reliability adjusted percentage of patients at a given hospital who received the intervention. And the x-axis is the hospital rank by treatment. So each dot is an actual hospital. One of these dots is University of Washington. I actually don't know which one it is. We looked at 4 different interventions: hydroxychloroquine, tocilizumab, proning, and neuromuscular blockade, to see if there was variation among hospitals. And for hydroxychloroquine, there was very little variation. With a couple of exceptions, most patients were receiving hydroxychloroquine. Remember, this was from very early in the pandemic when our esteemed former president was touting the benefits of this medication, and this is before the RCTs came out showing that it didn't work. Tocilizumab, the IL-6 antagonist, proning, and neuromuscular blockade, on the other hand, all have this dramatic variation from hospital to hospital. And what was even more interesting was interhospital variation in death. And again, I'll just remind you, these are adjusted for severity of illness, adjusted for age, basically adjusted for everything that I showed you in the multivariable models. And what you see here is the range in 28-day mortality ranging from 6% at the lowest risk hospital to 80% at the highest risk hospital. Really striking. So the last and probably most interesting part of what I want to talk to you about is whether data from Stop COVID can be used to assess the effect of treatment on outcomes, even though it's an observational study. So we believe the answer is yes, and we believe that the best way to do this is using a technique known as target trial emulation. And we were very fortunate to have the help of Miguel Hernan, a biostatistician here, who's arguably the most famous biostatistician in the world when it comes to this type of analysis. He literally wrote the textbook on how to do this type of analysis, and has really been pioneering this area known as target trial emulation. And one of his quotations, this is just from an email he sent me at some point, is that traditional observational studies that do not try to explicitly emulate a target trial have resulted in erroneous findings, such as the conclusion that postmenopausal hormone therapy was associated with a 30% lower risk of coronary artery disease, or that statin therapy was associated with a 44% lower risk of death in cancer patients. These findings become null, as they should be, when the observational analysis is designed to explicitly emulate the corresponding target trial. In other words, when you do the analysis correctly. Principles of target trial emulation are as follows. So the first is use similar eligibility criteria as you would for the corresponding RCT. If there's a patient who you would have excluded from the RCT, don't just adjust for that, exclude them so that you have a much more similar population in your observational study as you would in the RCT. Use the same time zero for both groups to avoid immortal time bias. Immortal time bias is an issue that does not really come up in randomized trials because patients are generally randomized at the same time zero, but it can be an issue in observational studies. And a ridiculous example of immortal time bias would be if ICU patients were offered tea and crumpets on ICU day 3. Subsequent analysis would likely find that tea and crumpet recipients have lower mortality than tea and crumpet non-recipients. Well, of course, because they had to survive to day 3 in the first place. 3 is adjust for baseline confounders to emulate random treatment assignment. And this is something that will be familiar to all of you. Standard regression is the most common way that we use to adjust for confounders, but there are, of course, other techniques such as matching and inverse probability weighting. And then 4th is analysis by intention to treat principle. The idea of comparing the effect of being assigned to treatment A versus treatment B at baseline, regardless of potential crossover later on. So this is something that is very familiar to people who do clinical trials. It's not really used in observational studies as frequently, but I think it makes sense to do so to avoid confounding. So we did 4 target trial emulations in Stop COVID, and we looked to look at the effects of tocilizumab, therapeutic anticoagulation, ECMO, and prone position ventilation on mortality. I won't have time to go through all 4 of them in detail, and I want to leave time for questions at the end, but I'll use tocilizumab as an example that I'll go into more detail on, and then the others I'll go through very quickly. So tocilizumab is a recombinant humanized monoclonal antibody against the IL-6 receptor. It's used to treat vasculitis and cytokine release syndrome, for example, in patients who receive CAR T-cell therapy and often develop cytokine release syndrome. The dose is 8 mg per kg IV once, although it can be given a second time. The onset is within 4 hours. The half-life is roughly 2 weeks, and the cost is roughly $5,000. So why examine tocilizumab in COVID-19? Well, we know that hyperinflammation may be an important driver of morbidity and mortality. We know this from the recovery trial, finding that dexamethasone has a major mortality benefit. Higher circulating levels of IL-6 have also been linked with worse outcomes in COVID. And early on, there were anecdotal reports from China and elsewhere of improved outcomes in patients with COVID who received toci. But these are case reports or case series of a dozen patients or so, and so not exactly the highest quality of evidence. So the question that we wanted to address was, does early treatment with toci improve survival? And we specifically were interested in early treatment because we hypothesized that if it's going to work early on before irreversible organ injury has occurred. So we published this paper also in JAMA IM last October. And here's the flow chart. So we started out with, at this point, we had 4,485 patients in our Stop COVID database. These patients had been admitted from early March to early May. We excluded patients if they would have been excluded from the corresponding randomized controlled trial. So for example, AST or ALT above 500 is an exclusion criteria for most toci RCTs. So we excluded them, and we excluded other patients for similar reasons. We ended up with 3,924 patients who we then categorized. I say categorized rather than randomized, because we didn't truly randomize them, but we're emulating a randomization. We categorized them by receipt of toci within 2 days of ICU admission. We had 433 patients who received toci within the first 2 days of ICU admission, and the remaining patients who did not receive toci. Now, these are some of the characteristics of the patients in the 2 groups, and you can see there are some imbalances. This is not a true RCT, so it's not surprising that there are some imbalances. And I just highlighted a few with the red arrows. So you can see age, for example. You can see that the toci-treated patients were a little bit younger, and they had fewer comorbidities. For example, they had less hypertension and less CHF. On the other hand, the toci-treated patients were sicker acutely. They were more hypoxemic based on a higher percentage of patients with a P to F ratio below 200, and they were also more inflamed. And we used various markers to define inflammation, like ferritin. So how do we deal with these imbalances? Well, we used a technique known as inverse probability weighting, or IPW, which is a propensity score-based approach where patients are assigned a certain amount of weight according to their likelihood of receiving or not receiving the intervention, in this case, tocilizumab. What you see on the y-axis is 28 characteristics, which we determined a priori to be potentially confounders of the relationship between a physician's decision to prescribe toci and the outcome, which was death. On the x-axis is the absolute standardized difference between groups. You can think of this as the same thing as the Cohen's effect size, which you may remember back to college level statistics. You may have remembered learning about Cohen's effect size, where an effect size of 0.2 is generally considered small, 0.5 is considered medium, and 0.8 is considered large. So that's why we have a vertical line at 0.2. Anything to the right of 0.2 we consider to be potentially important in terms of a large difference between groups. The black circles are the unweighted, and the red triangles are after applying the weighting. And so what you can see is that before we apply the weighting, there are a number of characteristics like inflammation and age that have absolute standardized differences greater than 0.2. But after we applied the weighting, all of the characteristics were less than 0.2. In other words, the IPW worked to create a pseudopopulation of patients with similar characteristics. And what we found was that the TOSI-treated patients had improved survival. You can see that with the Kaplan-Meier curve on the left, and you can also see it with the adjusted hazard ratio here from the Cox model, where the hazard ratio was 0.71, indicating a roughly 30% lower mortality in patients treated with TOSI compared to patients not treated with TOSI. And we had a number of sensitivity analyses, which I won't get into the details, but the results were consistent across the board. And then we also looked at subgroups. And one of the subgroups that jumped out was this days from symptom onset to ICU admission. And so patients who were ultra rapid progressors, basically those who had 3 or fewer days from symptom onset to ICU admission, seemed to be those who benefited the most from TOSI, with a hazard ratio of 0.4. And the p-value for interaction was significant. This was the only subgroup with a significant interaction. I'll also just highlight that it didn't seem to matter whether you were receiving steroids or not. Both groups of patients benefited from tocilizumab. So how do these results compare with subsequent RCTs? Well, on the exact same day that our paper was published in JAMA IM, the same journal published 2 RCTs, and the very next day, the New England Journal published an RCT. So within a 24-hour period, we had our study that came out showing a mortality benefit, and you had 3 RCTs, all of which were negative. Or one of these studies was sort of borderline, but essentially all 3 were negative. However, all 3 were highly underpowered. So these were RCTs of between 100 and 200 patients each. And we even published a letter to the editor in NEJM where we made 2 points. One was that the patients in these RCTs were not very sick. And you can see that by this graph, comparing our paper in blue to the RCT in NEJM in red. And you can see the difference, the percentage of patients admitted to the ICU, the percentage who were receiving mechanical ventilation on enrollment, and the percentage of patients who died within 28 days. The other major issue was, other than severity of illness, is that the event rate in the placebo group was far lower than the anticipated event rate. So they anticipated a 30% event rate for the primary outcome, which in this study I think was a composite of intubation or death. 30%, and their power calculation was based on on this 30% number, whereas in reality the event rate was 12%. And so that basically kills your statistical power. And we did a post hoc power calculation, and we basically said it would have been nearly impossible for the trial to have been positive with that event rate. It only would have been positive if TOSI reduced the outcome by more than 80%, which is highly implausible. So we were, I'm not sure what the right word is, relieved, I suppose, when a few months later, a much more definitive trial was published in NEJM, roughly 800 patients, all ICU patients, and there was a clear mortality benefit with tocilizumab, 28% hospital mortality versus 36% in the controls. 8% absolute reduction, or number needed to save a life, is 13. And then the definitive study came out in Lancet on May 1st of this year by the recovery group from the UK, the same group that published that initial dexamethasone paper that was so important. And this was a multi-center randomized open label trial conducted in 177 sites in the UK, 4,000 patients approximately, and there was a mortality benefit, again, with TOSI, 31% versus 35%, statistically significant. And this pretty much, I think, settled any question about whether TOSI has a mortality benefit. But interestingly, when they did subgroup analyses in the recovery group paper, the one subgroup that actually TOSI seemed to have more of a benefit was the exact same subgroup that we identified in our paper, which was those who had fewer days from symptom onset to hospital admission seemed to benefit more from TOSI. And if you're still not convinced, JAMA published a meta-analysis in July of over 10,000 patients from 27 separate RCTs, and the odds ratio for death was 0.83. Okay, so that's tocilizumab. I'm going to just talk very briefly about the other target trial emulations. So the second one we did was looking at therapeutic anticoagulation. So why examine therapeutic anticoagulation in COVID? Well, as I'm sure you all know, it's been proposed to be a key mechanism of death and acute organ injury. Early on in autopsy series, there were pulmonary thrombi and microangiopathy that were seen. But we had limited data on the efficacy of therapeutic anticoagulation. So in January, we published this paper, which I'll talk about, entitled Thrombosis, Bleeding, and the Observational Effect of Early Therapeutic Anticoagulation on Survival. So again, we were interested in early initiation of this therapy, which we defined as the first 2 days of ICU admission, comparing those who initiated anticoagulation versus those who did not. We excluded patients who were already on therapeutic anticoagulation prior to hospital admission, and we also excluded patients who had confirmed or suspected venous thromboembolic disease, those who were on ECMO, and various other exclusion criteria that you would apply if you were doing an RCT. And we found, long story short, we found no effect on survival with early initiation of therapeutic anticoagulation. We looked at every subgroup you could think of: age, sex, BMI, D-dimer level. Across the board, there was not a single subgroup that we could identify that seemed to benefit from anticoagulation. Okay, so how do these results compare with subsequent large RCTs? So just a few weeks ago, the New England Journal published the definitive RCT on this and basically found the same thing. So this was an open label, adaptive, randomized trial, over 1,000 critically ill patients assigned to therapeutic anticoagulation versus usual care. The primary outcome was organ support-free days, and the trial was actually stopped early for futility. They found, as you can see here, really with the overlapping curves between the two groups, and those who were assigned to therapeutic dose anticoagulation, not surprisingly, had a higher risk of major bleeding. Okay, so what about the other two? What about ECMO and proning? So unlike the first two that I talked about, where we have subsequent RCTs that were confirmatory, with ECMO and prone position ventilation, there have not been RCTs and likely never will be in COVID because of logistical challenges. And so in these settings, target trial emulation is probably the best, highest quality available data that we will ever have. So arguably even more important to do these types of studies. So ECMO, I'll skip over the details of ECMO in the interest of time. And basically we looked at patients who initiated ECMO in the first 7 days of ICU admission compared to those who did not. We used a nested target trial approach to address immortal time bias, which I can talk about more if people have questions about that. We looked at patients with severe hypoxemia, so those with a P/F ratio less than 100. We excluded patients if they were over age 70, because such patients are generally not candidates for ECMO, those who had active cancer, and those who were admitted to a hospital that did not have ECMO. So again, really trying to emulate what you would do in an actual RCT. And we found this major mortality benefit with ECMO. And the adjusted hazard ratio for death was 0.55. And then lastly, prone positioning and survival. So As I'm sure you all know, prone positioning is a well-studied intervention in severe ARDS in non-COVID settings, but we have limited data on its efficacy in COVID. I'll skip over this and just go right to the results, which is that the adjusted hazard ratio was 0.84, and it was significant. And this particular journal asked for 6 different sensitivity analyses, and pretty much across the board, there was a mortality benefit. So just to summarize, Stop COVID is a multi-center collaboration that collected data on over 5,000 critically ill patients with COVID-19, with over 800 data elements per patient. So that's over 4 million individual data elements that were each entered manually by human beings over a period of a few weeks in the midst of the pandemic. It was a multidisciplinary collaborative effort involving over 400 attendings, fellows, residents, medical students, nurses, and research coordinators from 68 medical centers across the US and from all different disciplines. It's a valuable resource for identifying risk factors for death and acute organ injury, and for investigating therapies that improve outcomes. And target trial emulation is a powerful tool that can be used in other settings, for example, future pandemics, to assess causality from observational data while awaiting the results of RCTs, or in some cases where we know that RCTs will never actually be performed, for example, in ECMO. Major findings. So patient-level risk factors for death included older age, male sex, morbid obesity, coronary artery disease, cancer, hypoxemia, and acute liver and kidney dysfunction. Considerable variation exists in both the treatments and outcomes among hospitals in the US, with admission to a smaller hospital being associated with a much greater risk of death. And in target trial emulations, survival was improved with TOSI, ECMO, and proning, but not with therapeutic anticoagulation. The first 17 published manuscripts from Stop COVID are shown on this slide and the next slide. I didn't have time to talk about all of these studies, but happy to if you want to have me back 17 different times, I'd be happy to talk about them. These are some additional studies that we published, and really across the spectrum. So ranging from AKI to machine learning to ABO phenotype, a lot of these studies were led by collaborators of ours from other institutions who basically applied, submitted a quick application to us in order to get access to the database, so it was really a great team effort, which is a great segue to this slide. I'd really like to thank first and foremost Shruti Gupta, my co-PI, my partner in crime. We were really in the weeds together on this. I remember early on in the pandemic, I would I'd call Shruti at 10 o'clock at night and say, turn on CNN. They're saying Texas is the latest hotspot. Who do we know in Texas? We got to get Texas on board. It was just a really crazy period, and I'm very grateful for all of her help. I'm also incredibly grateful to our biostatisticians, Miguel Hernan and Wei Wang, and most importantly, our 400 plus collaborators, including our collaborators from UW, Pavan and Bilal. Thank you for all of your help. This is my grant support, but again, Stop COVID was unfunded. And then finally, I'd like to thank my 3 children, Emma, Winston, and Teddy, for putting up with me basically being locked in my office for several months last year. Thank you.
Thank you so much, David, for presenting that work, an enormous accomplishment while locked in your pajamas in your office. Although I would still argue your wife probably had more work with the kids outside of the office.
Absolutely, absolutely.
So anyway, we definitely have time for questions, and it looks like Raj has his hand up. So go ahead, Raj.
David, congratulations for all the work that you've done. This is very impressive. Perhaps you mentioned that one of the things that I'd like to understand from you is the temporal trend in the risk of AKI and the outcomes with AKI in COVID through the course of the pandemic. It seems like there are some reports at least indicating that the risk may be decreasing over time, the outcomes may be better than they used to be. What are your thoughts on that?
Yeah, thank you. We have an AKI paper that we published in JSON that looking at risk factors for AKI and outcomes. It didn't really get into the temporal relationship because the patients in Stop COVID was a mad rush to enroll a lot of patients over a very short period of time. Patients who were admitted to ICUs between March and July of 2020. We pretty much stopped at that point after we had 5,000 patients, and I had to sort of get back to my other research that's actually funded. So Stop COVID was not well equipped to address questions of temporalness, but I have seen that a couple papers that have come out on that, and I haven't seen anyone offer a great explanation for it. But I would say that as the therapeutics have gotten better, particularly dexamethasone and tocilizumab, which are to this day, to my knowledge, the only two therapies that have been shown in COVID to have a survival benefit. I imagine they have a benefit with respect to AKI as well. So I think it just reflects that we're better at treating these patients overall.
Ian has comments and question, he says.
Yeah, thank you, David. Really fabulous talk, and my comments are really great work and pointing out the value of what you can do by organizing multi-center collaborative work, which brilliantly done, and also the value of observational studies of drug therapy, which many people question and which can be done poorly, to be sure, but when done well, I think offer a lot of value. So I just wanted to support that, and thank you for doing it well. And then my question was, we're learning a lot about the COVID epidemic. What of that? How are we going to apply this to the future? You've done a lot of this. You've probably thought about this. What of these findings in science and medicine that we've developed during the pandemic will persist, either for persistent COVID or for other critical care and nephrology?
Yeah, thank you, Ian. So I count myself as one of the people, someone who's was before this was guilty of not thinking epidemiologic research was as important as randomized controlled trials. Most of what I do is randomized controlled trials, and after this experience, I have a totally different outlook on that. And a well done epidemiologic study can be much more informative than a poorly done underpowered RCT. And the epidemiologic study can also be an enormous amount of work. So I think there's tremendous value. I think we demonstrated that value here by the two target trial emulations that where there were subsequently large RCTs. They basically found the exact same thing that we found, down to the level of the subgroup analysis in the case of tocilizumab. And we found this a year before the RCTs were published. We didn't publish it a year before because it takes a while to get stuff published. But I think while you're waiting for the RCT to come out, you have to base your practice on the best available data that we have. And so for future pandemics, I hope that people will take the lessons that we learned and collect data very quickly and analyze it, using the right techniques, and that can inform clinical practice, and it can also help inform the design of the RCTs themselves.
Dr. Watnick has a couple of questions. Go ahead, Suzanne.
Hey, David, that was really great. And I've just been back and forth with your partner in crime, Shruti. Really remarkable person also. Two things, thinking about patients requiring renal replacement therapy in the ICU, have you looked a little bit about the differences? Again, these are not randomized, I understand, with patients with AKI, either with or without CKD in the past, and also looking at end-stage kidney disease patients and how they're doing. I don't know if you have any insight on that. That'd be the first.
Yeah. Yes. So we do have a few papers on that, both AKI as well as CKD as well as ESRD. It would be hard for me to summarize all of those findings, but not surprisingly, CKD was the most important risk factor for AKI. One thing that was really interesting, though, that we found in terms of the AKI CKD relationship. So when we looked at patients with AKI requiring RRT, and we looked at their mortality, their basically their hospital mortality, which was extremely high. It was, I think, about 60% in hospital mortality. And when we looked at predictors of mortality, the patients with worse underlying CKD actually had a better survival, and it was totally not what we would have predicted. But if you think about it, those patients, if you're starting out with an eGFR of 17, you don't need nearly as big of a hemodynamic insult or whatever the insult is in order to get you to RRT. So that's the sort of the way we thought about it. If someone who starts out with normal kidney function, to get them onto RRT, they must have sustained a really severe insult.
Yeah, I really appreciate that. The second and last question I have, which is follow-up to that, is, there are a number of states now that are going to crisis levels of care. Alaska is the latest out here. And, especially when you're talking about allocating resources, there has been discussion about patients requiring maintenance dialysis, and how do you allocate dialysis to different populations when they're critically ill in the ICU? So I think it's important to look at some of the observational information that you're sharing, that maybe those patients who either had advanced CKD or required maintenance dialysis didn't necessarily do worse with those who had no underlying kidney disease and AKI. I don't know if you have any thoughts about that.
Yeah, so we have a paper on so the second from the bottom here on performance of crisis standards of care using our data. We looked at Colorado and New York because they were sort of representative of the two different types of crisis standards of care used, which is that most states rely on the SOFA score, but some states rely on also incorporate comorbidities like CKD and ESRD. So we compared them, and the bottom line was they both performed horribly at predicting who's going to survive. Almost as bad as a coin flip. It was really shocking. And so the take-home message there is just that we need better to help predict who to allocate those resources to.
Thanks so much.
Other questions for David? I have one question, David, which is, obviously you outlined how quickly you put together the collaboration, but the enormous amount of work that went into it. It sort of raises the question of, should that type of work be done proactively before the next pandemic or before the next national crisis, rather than trying to do such collaborative work once it's already happened? I'm just curious what your thoughts are on that, about research collaborations moving forward.
Absolutely. I mean, we're probably the only country in the Western world that where we have this crazy system where we don't have a universal electronic health record system, and we had the amount of and the fact that we had to have 68 separate IRB approvals. I mean, I talked to our IRB folks and I said, can we do this with a single IRB? They said yes, but it will actually take longer. So I mean, the amount of effort that was just enormous. There needs to be a better system, without a doubt. In other countries have done epidemiologic studies in COVID, of course, where they don't have to deal with all the red tape of and all the merging of different EHRs, but you still get into the issue of the granularity of the data when you do just a big data pull, as opposed to doing the manual chart review. And I'm still sort of, maybe I'm old-fashioned, but I still believe in the value of manually reviewing charts. I mean, somebody has an ICD-9 code for diabetes versus reading that they have diabetes in the chart. It's just not the same thing. And certain physiologic parameters like the P to F ratio, pressors, these are things that are constantly changing. You can get that if you have a really good programmer and you have a lot of time, you can do it. But across 68 different centers, with each of them with their own EHR, there was just no way that we could have done this in a more efficient way than the 10,000 hours of human the 10,000 hours of work that went into it.
Final questions for David. There's a question from one of our second-year fellows. Any thoughts on why initially earlier in the pandemic there was no difference in mortality seen with race? I'm not sure, Laura, if I'm capturing your question.
Yeah, that's a great question. So the issue with race, we're not the only ones that have found this. Actually, there was a paper from New Orleans early on, which published in the New England Journal, that found similar findings as us, which is that once you're admitted to the hospital, race doesn't seem to make a big difference. That they found that in their paper, which was all hospitalized patients. We found that in our study, which was just ICU patients. But Black patients do seem to be disproportionately admitted to the hospital and to the ICU. So, for example, Black patients comprise 30% of the patients in our cohort, but they are 13% of the general population. Now, I mean, our study was mostly large hospitals, which is mostly cities. So, that 13% number is probably not the right number. You'd want to know what's the percentage of Black patients in the geographic locations where we had patients, but it still seems like they were overrepresented. So I think being really sick in the hospital is kind of an equalizer, but there certainly do seem to be disparities in terms of getting COVID in the first place and then getting sick enough to be admitted to the hospital.
Thank you so much, David, for a wonderful presentation and for just the huge amount of work that you've done over the last 18 months. And we'll see everyone next week back at Nephrology Grand Rounds, and have a great weekend.
Thanks very much for having me. It was great. Appreciate it.